Hello, my name is Alina Allen. I am from Mayo Clinic, Rochester, Minnesota. I would like to thank the editors for the invitation to discuss our research regarding chronic kidney disease after liver transplantation and its impact on mortality, which will be published in the Journal of Hepatology. As you know, the field of liver transplantation has evolved tremendously for the past 3 decades. As patient survival increased, so have the rates of late complications, such as chronic kidney disease. This is a major clinical issue because renal disease is one of the most important causes of death in this patient population. The true burden of chronic kidney disease after liver transplantation is underestimated. Most studies have reported only the percentages of advanced renal disease, which is present in a relatively small percentage of patients. In addition, renal function was estimated using creatinine-based equations, which overestimate GFR in this patient population. In this study, we measured GFR to assess the renal outcomes in liver graft recipients who are long-term survivors. We aim to determine not only the rates of advanced renal disease, but also to see what happens to the renal function in the majority of remaining subjects. The study population included all adults who underwent liver transplantation at our institution between 1985 and 2012, who were prospectively tracked in the transplant database. This included over 1,200 subjects who were followed up to 26 years. Our post-transplant protocol involves yearly measurement of GFR in all patients. One of the most important findings of this study is that chronic kidney disease is almost the rule after liver transplantation. For example, of all patients who survive at 25 years, only 19% of them maintain a normal kidney function. This ratio is strikingly less than the general population of the same age range, of whom 40% have a normal renal function. An overwhelming majority of liver transplant recipients develop moderate to severe CKD. Almost 60% of subjects had a GFR of below 60 as soon as 1 year post-transplantation. Throughout the follow-up, the most predominant stage was stage 3 CKD, depicted in purple in the figure, while advanced kidney disease was noted in 24% of liver graft survivors at 25 years. Almost 9% of liver graft recipients underwent subsequent kidney transplantation. Another practically important observation of this study is the limitation of the estimated GFR data. For example, the 4-variable MDRD equation, which is reported automatically with creatinine results in most of the laboratories. When compared to measured GFR, MDRD underestimates the rate of patients with normal kidney disease and with normal kidney function and advanced kidney disease, thus the extremes of the GFR spectrum, and overestimates moderate kidney disease. Another very important observation is that the decline in renal function is biphasic. The first phase represents a steep decline in GFR within the first year post-transplant, noted as early as at 4 months. The ensuing second phase is more gradual but progressive for years to come. We could not identify any risk factors for early chronic kidney disease in a random sample of patients. In the majority of cases, the GFR decline was subtle and progressive and attributed by clinicians to the renotoxicity of immunosuppressive agents. We then aim to determine the impact of renal disease after liver transplantation on survival in a time-dependent analysis. Using measured GFR, we found that the risk of death starts to increase as early as GFR of 60. Clearly, further decline in GFR is associated with higher risk of death, up to 5-fold. MDRD underestimated the risk of mortality. In summary, chronic kidney disease is a very common complication after liver transplantation. A vast proportion of patients have a GFR below 60 within the first year after liver transplantation, a threshold at which the risk of death starts to increase. Our current therapeutic options for reversal of chronic kidney disease are limited. Therefore, our focus as transplant hepatologists should be on prevention and early detection of renal dysfunction. Various preventative measures could be considered. First, prevention and timely reversal of acute kidney injury in the perioperative state is very important. Second, post-liver transplant protocols should involve multidisciplinary management of comorbidities, such as diabetes, hypertension, and obesity, which are known risk factors for renal disease. Lastly, and more importantly, the need for immunosuppressive agents without renal toxicity cannot be overemphasized. Early detection of renal dysfunction entails diligent monitoring, which may require measurement of GFR. Close follow-up should start early, as the first year post-transplant seems to be critical. As soon as subtle GFR decreases are noted, changes in immunosuppressive agents and avoidance of all potential nephrotoxics should be considered. Thank you for your attention.